Hello, this is Kyung from Dongguk University Kyung Hospital, Gyeongju, Korea. Repeat prostate biopsy must be considered when PSA is persistently elevated or clinical suspicion of prostate cancer persists. But there are no definite guidelines on when or where to repeat biopsies in patients with negative findings on initial prostate biopsy. We reviewed a total of 7,001 patients underwent transrectal ultrasound-guided biopsy from 2000 to 2012 at 6 centers in Daegu and Gyeongbuk province. Of the patients with negative initial biopsy findings, 374 patients with a persistently elevated PSA, an increase in PSA during follow-up, persistent nodule or asymmetry by digital rectal examination, and high-grade prostatic intraepithelial neoplasia, and atypical. A total of 7,001 patients were underwent transrectal ultrasound-guided needle biopsy. 2,118 of these patients were positive for prostate cancer, and prostate cancer detection rate was 30.3% at initial biopsy. Of the patients who had a negative initial biopsy, 374 patients were underwent repeat biopsy. 86 of 374 patients were positive for prostate cancer, and prostate cancer detection rate was 23% at repeat biopsy. The clinical characteristics of initial and repeat biopsy groups who had an organ-confined disease were summarized in this slide. Patients with prostate cancer diagnosed at repeat biopsy were significantly younger, had larger number of biopsy cores, smaller number of cancer-positive cores, had cancer core per biopsy core ratio, and lower initial Gleason score than patients with prostate cancer diagnosed at initial biopsy. Characteristics of initial and repeat biopsy groups who underwent radical prostatectomy were summarized in Table 3. Patients with prostate cancer diagnosed at repeat biopsy had a larger number of biopsy cores, smaller number of cancer-positive cores, lower cancer core per biopsy core ratio, lower initial Gleason score, and lower pathological Gleason score than patients with prostate cancer diagnosed at initial biopsy. Percentage of pathologic stage T2 or less were 65% and 85.7% of pathological T3 or more was 35% and 14.3% at initial and repeat biopsy, respectively. These results suggest that the patient diagnosed at repeat biopsy had a more favorable clinical stage distribution than those diagnosed at an initial biopsy. Percentage with a biopsy Gleason score of less than 6 at initial and repeat biopsy were 24.5% and 52.2%, and pathologic Gleason score were 20% and 45%. These data suggest that the rate of more favorable cancer is higher than in repeat biopsy. This slide shows percentage of prostate cancer detected at initial and repeat biopsy according to PSA level. Multivariate Cox regression analysis showed that number of cancer core more than 2 was an independent predictor of high-grade cancer detected at repeat biopsy. In conclusion, cancers detected at repeat biopsy tends to have a lower Gleason scores and stages than cancers detected at initial biopsy. We concluded that repeat biopsy is needed in patients with a persistently high PSA or abnormal DRE findings more actively. Thank you.